Right, extra-articular deformities and knee replacement. Now, I must say these are not common cases and not something that we encounter every day. So before we start looking into it, we need to know what the basics of knee replacement are, what we're trying to achieve. As we know through our training years, the knee replacement is a soft tissue procedure with bony cuts. What we look at, or what we want to achieve, is a well-balanced knee with a good range of motion and a good sagittal and coronal balance and a good patellar tracking. The bony cuts need to preserve the ligaments, the collaterals, and the end result needs to be a joint line that is perpendicular to the mechanical axis of the lower limb. And this is the same that we aim for any knee replacement, whether it's got an intra-articular deformity or an extra-articular deformity. Now, deformities are fairly common if you look at general population that we encounter for knee replacement. They can be intra-articular, which are most easily dealt with, with soft tissue releases and bony cuts. And then we have extra-articular, which is the main topic of my talk. Now, they are much less common, and they can be missed. According to one paper, even up to 50% can be missed if you X-ray just the knee. Now, this is one of my cases from a little while ago. And sorry for the screenshot, it's not really clear. But if you do the full leg view, it's a whole different story. So there isn't a unified classification system of extra-articular deformities, but a simple one is to divide them into simple and complex, because that's what guides you to treatment later on. They can be uniplanar, which is simple, but they can be bi- or triplanar. They can be near or far from the joint, i.e. metaphyseal or diphyseal. They can be congenital or acquired. Now, they can be a result of some childhood bone metabolic disease, or they can be acquired from trauma, which is much more common of cases that we encounter. They can be due to infection, chronic osteomyelitis. They can be due to previous surgery, osteotomies being one of them. And last but not the least, we mustn't forget rare cases like tumors and Paget's. Now, when we start assessing these patients, start with a detailed history. There's no harm in asking a 65-year-old about how the childhood was, because it could be that they had the deformity right from birth or early childhood. You need to know about any history of trauma, any sort of surgery that was done to them, what procedure was done, whether there was any post-operative issue, infection being one of them, any wound problem, because that's going to direct you as to what you're going to do when you treat them. Examination, full exposure. Don't be shy to have a look at the whole leg, starting from the hip all the way down to the knee. We need to look at the joints above and below, leg length discrepancy, which can be with an extra-articular deformity, any previous scars, whether surgical or traumatic, sinuses, pin sites from X-fix, what the soft tissues are like, and obviously neurovascular status. Now, your examination will direct your investigations mostly, but there are a couple of things which are absolute must. Standing X-rays, obviously, but you need mechanical axis views in these patients. Now, if you see an angry-looking knee like this, you may want to have a CT scan, and especially if there's a complex triplanar deformity, CT scans will be required. You may want to have an MRI scan. And in cases where you suspect infection, even an isotope or a SPECT CT. Now, preoperative planning is the key. These are not the cases which you see day in, day out. So you wouldn't put them on your first waiting list. You would want to think about it a little bit and plan. Now, when you see an X-ray with a deformity like this, you need to plan how to encounter that, whether you can accept it with a standard knee replacement, or you need stems, you need an osteotomy, or whatnot. You need to assess for leg length discrepancy as well. Somebody who has a short leg with a large deformity, this will take some thinking. Now, in terms of surgical options, there are two main ways of dealing with it. Intra-articular bone resection, which is pretty much what we do in standard knee replacements, along with soft tissue releases. They can deal with most of mild or moderate deformities, and we'll come to that later. And in some cases, the deformities are severe enough that you would want to do an osteotomy, whether as a two-stage procedure or as a single-stage procedure. It all depends on the extent of deformity. Now, in order to assess how bad the deformity is, there are various preoperative assessment techniques described in the literature, some algorithms. Assessment tools need to be simple and reproducible. Unfortunately, there are none in the literature, but I'll go through a couple. This is one given from the Hospital of Special Surgery, and basically what they start with is how severe the deformity of the tibia or the femur is. Now, the acceptable limit from this study was 30 degrees of angular deformity in the in the tibia, and 20 degrees in the femur. Angular deformity, whether it's in the sagittal plane or a coronal plane. If we have a triplanar deformity, which means there is a rotational deformity as well, then we cannot follow this algorithm. So there are some caveats. Now, another way of assessing, which Santiago tried to simplify, was to look at the mechanical axis of individual bone. Now, as we know that the aim is to preserve the collaterals, to keep the surgery simple. In terms of the femur, if you have a line perpendicular to the mechanical axis of the femur, and that passes below the insertion of collateral ligaments, an intra-articular bone resection could be carried out. On the tibia side, if you draw a line from distal to proximal along the mechanical axis of tibia, and it passes through the tibial articular surface, the deformity is mild enough to go for an intra-articular bone resection. However, if the lines go above, the perpendicular line in the femur goes above the insertion of collaterals, then obviously a simple knee replacement is out, so bone resection isn't the answer. And similarly, the tibia. Now, from both these, the American algorithm and this paper from Santiago, the consensus was on 20 degrees of deformity in the femur and 30 degrees in tibia. This is one case, distal femoral malunion, treated with intra-articular bone resection. This is one of my cases. Again, intra-articular bone resection dealt with this deformity. Now, if you look at just the knee X-ray, you might think that there's a varus knee cut, but if you look at the whole picture, the joint line is perpendicular to the mechanical axis. And this is what the computer navigation and robotics has exploited over the years, and we see less and less of osteotomies. Now, if you do have to perform an osteotomy, whether it's a one-stage or two-stage, it depends on any additional factors like leg length difference, complexity, where you need a circular frame, or previous hardware. This is a case that we discussed earlier. Looks pretty innocuous on the AP, but this required an osteotomy, bone grafting, and then followed by a standard knee replacement. The osteotomy was stabilized with a nail. Or you can stabilize the osteotomy with a stemmed implant in a similar case. And this is a case where you have leg length discrepancy with a femoral deformity. This will need correction of deformity first. So in this case, an expandable nail was used to gain length as well as correction of deformity, and then a standard knee replacement. There are complications, though, of the osteotomies: osteomyelitis, non-union, soft tissue problems. And that is why more and more literature is now coming to sway away from osteotomies, and that's where the navigation comes in. Now, unfortunately, because they're not common cases, most of the literature is essentially short case series with the short follow-up. And similar is the case with intra-articular bone resection. So in conclusion, these are not common cases. These can be quite challenging. It needs careful preoperative planning, and the surgical procedure needs to be as simple as possible. It needs to be done by an experienced surgeon. Thank you.
Thank you very much.